All right, so this is a group of questions that I built. If you notice that it looks a little bit like AI, it's because I use AI to rephrase it to make it sound better. Okay, so this is a group of questions that I did for the topics of gastritis, GERD, and ulcers. All right, so let's start. We have a client with acute gastritis, reports epigastric pain and nausea. Which assessment finding most strongly support this diagnosis? We have pain relief by eating, black terry stools, epigastric tenderness and vomiting, D. Rebound tenderness in the right lower quadrant. In this case, the right answer will be C. Epigastric tenderness and vomiting. Why? Because we're talking about gastritis. We're talking about a direct lining inflammation of the stomach. All right. So when the stomach is getting inflamed, you're gonna have epigastric pain, nausea, and vomiting. Why not A? Pain relief by eating. That's more like duodenal ulcer. If you have pain relief by eating, that's duodenal ulcer. B is that's melena. And we usually see that when it's actually bleeding because of an ulcer, not simple just gastritis. And D, whenever you hear rebound tenderness in the right lower quadrant, appendicitis. All right, that's a typical clinical manifestation of appendicitis. All right, next question. Which medication is commonly prescribed to reduce gastritis acid secretion in clients with gastritis? Sorry, let me rephrase. Which medication is commonly prescribed to reduce gastric acid secretion in a client with gastritis? Okay, we have metoclopramide, omeprazole, sucralfate, and ondansetron. Which one do you think it is? Yeah, it's omeprazole. Why? The ending of prazole, which means PPI. This is a proton pump inhibitor. Usually will be shutting down the production of acid in the stomach. So it lowers a lot the amount of acid in the stomach. Why not metoclopramide? Because metoclopramide is more for motility, not for control of the acidity. Sucralfate is more for coating the stomach. It doesn't actually suppress the acid. And ondansetron is an antiemetic only medication. Right, next question. The nurse is providing discharge teaching to a client with gastritis. Which statement indicates understanding? A says, I should take non-steroidal anti-inflammatory drugs on an empty stomach. Alcohol can worsen my symptoms. Spicy food help neutralize acid. I can stop the medication once pain's resolved. What do you think it is? Easy, right? Whenever you hear about alcohol, I don't know you, but if you know, let me know in the comments. But I have no idea. I haven't heard anywhere about anything or any condition in which alcohol is good. Unless you have like a cut or something and you're trying to clean the wound, alcohol is not. It's never this. It's not good. So alcohol irritates the gastric stomach mucosa. Now, when we talk about non-steroidal anti-inflammatory drugs, NSAIDs, that causes gastritis. Spicy food, really, gastritis, acid is and D. I can stop the medication when pain resolves. In most nursing questions, whenever it says, "Oh, I can stop my medication if I get better," no, 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 no. If the doctor says you're gonna take this for 5 weeks, you take it for 5 weeks. Oh, I feel better now. No, no. The order in most questions, that's the solution. All right, next. Which symptoms is more characteristic of GERD? GERD when you're having the reflux that's going up. So which of these? We have sudden epigastric pain, burning chest after meals, pain relief by antacid only at night, and projectile vomiting. What do you think it is? Yes, it's burning chest pain after meals. Why? Why do you think we have stomach acid? The actual reason is because we have to destroy the food that we're eating into more chemical simple substances, right? So the more you eat, the more acid you're gonna have in your stomach. So if you have GERD and you start eating, you're gonna have a lot of more acid because your stomach is producing acid to destroy that food into simple compounds. So why not A? Because the A says sudden severe epigastric pain. That's more like a perforation or a pancreatitis. That's not this. A night only pain. That's not classic for GERD. And projectile vomiting is when you hear about projectile vomiting, it's usually when the patient have an obstruction. Imagine you have the esophagus that goes all the way down, and then you have the stomach, and then you have the duodenum. Imagine in that part there is like an obstruction, and all of the sudden all the food that goes to the stomach cannot go up, cannot go down, sorry. Are you gonna do? Well, you're gonna vomit like hard because your body cannot keep moving that down. So it's gonna be like a projectile, like boom, going to the outside, right? Okay, next we have a client with GERD is prescribed pantoprazole. Prazole, we already talked about PPIs before. What is the primary purpose of this medication? Neutralize stomach acid, increase gastric motility, suppress gastric acid secretion, or coat the esophagus. Yep, if you said C, you might be right. It's actually suppressing the gastric acid secretion. It suppresses it. It's like no more acid for now, right? That's usually why we take it in the morning, so the effect lasts the whole day. So PPI block something called proton pump, which is basically just increasing the amount of acid that is in the stomach. So why not A? Because it's not about neutralization. When you say neutralization, is when the acid is already there and we're reducing the level of acidity. PPIs doesn't do that. They prevent the acid from getting produced. It's not the same preventing someone from growing than preventing the acid from growing than neutralizing the acidity level, which is anti-acid. Okay, so why no motility? Why not B? That's that's metoclopramide. Motility, we're not talking about motility. We're talking about acid in the stomach. This is GERD, this is reflux. And D, no. When we talk about coating in the esophagus, we're usually talking about sucralfate, right? We're usually not talking about pantoprazole. All right, next question. Which complication is a long-term risk of unrelated GERD? Appendicitis, Barrett's esophagus, Crohn's disease, intestinal obstruction. Okay, I'm gonna go quick on this one because if you don't know, you will know now. It's something called Barrett's esophagus. What is this? There is a phrase that goes that what doesn't kill you make you stronger, right? Well, it's kind of like this. When you're having a lot of acid in your esophagus, which is GERD, it's just a lot of acid going up, like the reflux. A part of your esophagus, a part of it, is gonna try to get stronger. It's gonna try to grow and get thicker to be able to survive this level of acidity that he's receiving. So um, it's actually a good response if you think about it, because it's protecting your body. It's getting stronger, it's getting thicker, the tissue to protect you. But at the same time, by doing so, since it's growing so fast, usually in the body, when a tissue that is not growing in general that starts growing has a higher risk for developing cancer. And this is why Barrett's esophagus, even though it sounds like, oh, that sounds cool, that sounds good. No, it's not. It's dangerous. And it can be an indicator that we have a higher risk for cancer in the esophagus. Okay? Next question. Which factor is most commonly associated with the development of peptic ulcer? If we have high fiber diet, high fiber, high fiber diet, chronic non-steroidal anti-inflammatory use, excess insulin production, and viral infection. Which one do you think it is? Yes, non-steroids, anti-inflammatory. Why? Because maybe you learned this about in farm, this kind of medication, they reduce something called prostaglandins, which is pretty much the protectors of your mucosa, of the mucosa in your stomach. No prostaglandins, no mucosa protection. All right? So why not A? I mean, fiber is protective, but it's not what we're looking for here. Fiber is protective. Fiber is not gonna produce. Is gonna not produce as an ulcer. Insulin, that's not related. And ulcer are bacterial, not viral. So when you talk about gastritis and ulcers, we usually talk about H. pylori, which is a bacteria, but I haven't heard about any virus or virus condition that is related to ulcers. Most of the time, it's bacteria, and 90% of those, or 99% of those bacteria, don't quote me on this, but it's usually H. pylori. Now we have a client with a gastric ulcer which reports worsening pain after meals. The nurse understands this finding is, what do you think? Yes, characteristic of gastric ulcer. You know, we talked about before in one of the other questions. If you eat, your stomach starts producing acid, right, to be able to digest that. So food increases the acid in the stomach, and then you're gonna have a lot of ulcers, a lot of gastritis. Now, why not A? This is unexpected. No, this is expected. As I said, this is normal. GERD, indicative of a GERD. No, GERD doesn't mean that it's an ulcer. Acid in the stomach, like gastritis, can lead to, can be shown as GERD, can lead to ulcer, but it doesn't mean that it's an ulcer. All right? And then we have a sign of intestinal perforation. I mean, no, a perforation is more about severe pain, and it's sudden severe pain that you have out of, you're like, it's like more sudden. It occurs out of nowhere, and it's actually like severe sudden pain. It's more like a real, more stronger level of pain. Okay, which assessment findings suggest a bleeding peptic ulcer? We have clay color stool, hematemesis, abdominal distension, and decreased bowel sounds. Okay, this is the last question, so hope you got it. It should be hematemesis. If you don't know, don't worry, we're here to learn. What is hematemesis? Um, it's pretty much you just vomiting blood. As simple as that, right? Yeah, you're vomiting bright red blood. Imagine you have an ulcer, which is damage in the tissue of the stomach. It's a little hole, let's say like that, and the tissue it is still got a little bit of bleeding in the stomach. So that blood goes to your stomach, and when you vomit, there's gonna be blood in there, That's why we say hematemesis. Hemat, this when the way you see these four letters HEMA, that's usually blood. Emesis, that's usually vomit, right? So abdominal distension, decreased bowel sound, that's not related. Oh, sorry, yeah, anyways, yeah, this is the last question. Hope you guys liked it, and let me know in the comments if this kind of formats it's of your liking and if you want more of this. And if any considerations, any recommendations, just let me know. I'm here to help you. I'm also struggling a little bit with nursing school, so I just want to help you everyone with this. Thank you. Have a good night.